think it's going to work. There's no problem. Okay, guys, welcome to this fantastic, exciting evening. It's called the Evening with the Desi Boys. So the whole concept of ASSICON 2024 was to get together the stars or the brain drain from our country, the big stars that have gone away and have created a buzz where they've been, and they've created a big name for themselves, and we are trying to rope them back into our scheme of things, and this might be the first step towards that. All the people that you're going to listen to today are essentially Desi boys who are our flesh and blood. So we are very, very proud of the work they're doing, and we hope that this turns out as a collaboration in the future of some kind. With this, I may hand over proceedings to Dr. Shailesh Hadgaonkar, a very, very special spine surgeon from Pune, who's prolific, modern, and does a few new surgeries every year. And you have to see what he does to believe what he says. Shailesh, it's all yours.
Thank you, Dr. Nene, for this wonderful introduction for this show on a global platform. And I welcome you all for this wonderful ASSI live course. And we will have a lot of experiences and detailing from all of you. Without ado, I would like to invite Dr. Ketan Badani, who is the president of Bombay Orthopaedic Society, the Mumbai Orthopaedic Society, and Mumbai Spine Society, for giving his special address for this world webinar today on behalf of ASSI BSS joint venture. Over to you, Dr. Badani.
Hello. Good morning to some, good evening to some, and I welcome all of you, esteemed speakers from all over the world who have originated from India and have made their mark in different parts of the world with their enormous amount of work and scientific material that has been done. This is a very novel concept. Our ASSICON 2024 has actually started even before the actual meeting, and that is the new concept that has been designed by us, where we have these webinars which will be then kept a live telecast during the conference for people to attend to. And so this is actually pre-ASSICON events, and this is a one-of-a-kind event where all our people who are in different parts of the world are participating and giving their excellent knowledge to all of us. With this, I hand over to Dr. Chahal to give his welcome on behalf of the ASSI.
Good morning, good evening, and on the behalf of the Association of Spine Surgeons of India, we welcome you all. This is a very interesting topic and a very interesting name, Desi Boys. As from North, I can say Desi Boys have been hit both in music and in the medical field, as we see you doing your tremendous work and meeting you at all conferences. We thank you for being with us for every opportunity you get it. You have never said no to any of our conferences, any invitations. That is a great giveaway to your country and to your association. You have mentored thousands of students, and whenever we go to you, we feel that we are at home. And I had the pleasure of such a stay with Dilip da, and America was another home for us at that time. And thank you, Dr. Badani and the Bombay Society, for hosting a wonderful event and planned well. And I wish you all the best. Thank you.
Thank you, Dr. Chahal, who is the Secretary of Association of Spine Surgeons of India. And we move on with our presentation today. We would like to start with Dr. Vishal Sarwahi, who is practicing at the New Hyde Park in New York, and he's a spine surgeon trained in Mumbai. And we would like to know insights from Dr. Vishal about the complications in EOS. And he's a phenomenal deformity surgeon. We know that his work, and we have seen his publications. Let's see about the most important topic, complications, and let's understand. If you have any questions, please send it to us. We'll definitely try to answer one by one whenever we get time. Over to you, Dr. Vishal.
Good evening from New York. My first surgical case was a 20-year-old with a lot of congenital deformities, multiple hemivertebral bad deformities. And I took it to Dr. Boachi, who was my mentor at that time. And he said, Vish, don't get complications the first year, send the patient to me. I see him a year later, and Boachi tells me, well, that kid that you sent me got paralyzed. So that is essentially the gist of the talk. Life happens, shit happens, and it happens a lot to a lot of people. And as I go through this, we'll talk about some of that. So good evening to all of you, and I would like to thank Dr. Nene and the committee for inviting me. I have a complicated topic, management of complications in early onset scoliosis. I'm going to present some of my own complications of some of my partners. I usually blame my partners for a lot of these. And then we'll see how we manage this. And hopefully you'll learn some tips from avoiding these. My gist of this is essentially the American Disability Act, ADA. I call it avoid, delay, and anticipate. And that is a good rule to follow in early onset scoliosis, because complications are almost guaranteed. You will get them, and there are a variety of them, be it implant-related, be it patient-related. So I'll start with my first case, a 9-year-old juvenile kyphoscoliosis patient, 24 weeks, premature birth, cerebral hemorrhage and hydrocephalus. Recent MRI shows increased T2 signal, expansion of the cord from C1 to C6. Child is neurologically normal. Neurosurgery clears the patient. This is her x-rays before surgery, 76 degrees, 64 degrees, almost 60 degrees of kyphosis. This is her 2 months after the surgery. The proximal implants have pulled out. Patient has PJK. So again, very frequently the implants will fail, and oftentimes a lot of these distraction implants will lead to a proximal junctional kyphosis. So my partner decides to revise this, and during correction, there's a complete loss of signals, both sensories and motors. Patient has woken up, patient moves her legs, and the signals return. Both SSCPs and MEPs come back completely. So my partner decides to keep the instrumentation. At the end of the surgery, patient is moving all limbs postoperatively. So you anticipate a good day, but 24 hours later, well, the sensory and the motor are being lost again in the right leg, eventually in the left leg, and an hour later, everything is gone. CAT scan shows no screw misplacement. So this is when I come in. This is how it looked before the implants were removed. This is a CAT scan showing you the screws were fine. Again, these are some slides. The MRI shows no abnormality. So we remove the implants. We do laminotomy from T3 to T7. There were no signals before and after removal. Postoperatively, when the patient wakes up, there's a complete return of strength and sensations in both the legs. MRI immediately, 1 week and 1 month is normal. And now this is how she is postoperatively without the implants. The curve has increased a little bit. The kyphosis and lordosis are still the same. A year later, my partner brings the patient back to attempt to correct this, and we have no signals. So obviously, we decide not to go ahead. And now, a year later, this is how she looks. So worsened deformity, both kyphosis and scoliosis. If following a year after that, he gets some signals. So he only has MEPs in the tibialis anterior and anal sphincter, no SSCPs. He decides to go ahead, puts the screws in, but decides not to attempt any correction. So in lieu of that, he puts in 2 magic rods on each side, trying to attempt a gradual, slow correction while the patient is awake. And after 1 year, not much of correction has happened with the magic rod, as you can anticipate. And this is where she is. The patient the magic rods have been removed, and basically an inside fusion was carried out with the rods instead. And these are Z rods, which you see. So this is now where the patient comes to me a year later, and I decide, despite all those neurological events, to go ahead and do a vertebral column dissection just to improve her kyphosis. And that's what I did, a T8 vertebral column dissection. It was uneventful, and this is how the patient is. On your right-hand side is the sagittal x-rays showing the correction of the kyphosis. Of course, a year has passed, and now the patient comes back, wants me to fix the lumbar deformity also, and I'm still kind of debating about it. So the lesson to be learned is be prepared to tackle the unknown. I mean, these are the problems that can happen at any time to anyone, and if you most of the time act appropriately, you just may get lucky, but not all the time. On to the next case. Plenty of rib fractures, pneumothorax, implant pullout, implant failure. And that will explain to you why I really hate rib hooks. People put them still, and I'm actually absolutely against them. This is a 7-year-old female, 62-degree curve. Again, another of my partner, while doing a left side distraction of the rib hooks, ends up with a pneumothorax. I get called in. It's easy to repair a pneumothorax whenever you have a pleural leak, because I do a lot of thoracoplasty even for routine AIS. You can occasionally see pleural leak. All you do is put in a red rubber catheter, attach it to a suction, and take a purse-string suture. And as you close it, you can pull the red rubber catheter out, and usually don't need to end up needing a chest tube. So again, ribs are not a good fixation point, and if you can avoid it, always avoid it. Again, this patient ended up with rib fixation, and sure enough, a year later, the proximal fixations have pulled out. Undergoes revision, reinsertion of the rib hooks. Sure enough, 2 years later, it pulls out. This time my partner decides to take out the offending rib hooks and the rod, and leaves him with only one side magic rod. And if you have not anticipated this by now, you should be surprised to see that even magic rods, single ones, can fail. And of course, this breaks away. Luckily, the patient is old enough, 10 years old, and my partner decides to do a full fusion. And that is why I hate rib hooks. And just to make my point again, another kid, another young one, and again, another my partner puts in these proximal hooks, and sure enough, they pull out. And finally, I convince them to start going towards proximally 3 levels fixation with pedicle screws and 3 levels at the bottom, and fuse them away. So these are your foundation. These usually will not pull out if you're still trying to do magic rod or any growing rod construct. And it's not, the rib hooks are not just for the magic rods, even for routine growing rods. And this is one of another patient, 4-year-old with almost 110, 120 degree scoliosis. And again, the same story, the rib hooks pulled out. So that is my message. Stay away from the ribs. Chest is not our area of expertise. And I forget which book it was, by the Bailey Love or Hutchison, which said the ability to perform a procedure is not an indication itself. Just because we know how to put hooks in the ribs, we should not try to put them. The ribs are not a good fixation point, and when you distract across the chest, you actually take away the bucket handle movement of the ribs, and you cause more problems to the chest. It's like a concrete slab rather than helping it. So the next thing is choose wisely, and of course, delay. If you can avoid surgery early on, be it using casting, be it bracing, or just watching, just delay. This is a patient of mine. This was when she was 7 years of age. I delayed the surgery. Now she's about 10, and I decided to go ahead and put in a magic rod here. Now notice I've put in a tether up top on the right side because I'm worried about distraction, which it leads to proximal junctional kyphosis, and having a posterior tether helps. And this is her 2 years later, and I finally ended up operating on him and fusing her. Again, despite doing distraction, the best correction is at the time of surgery, initial surgery, not subsequent distraction. So you will see a lot of these will not end up getting a great correction, and you may end up resorting to osteotomies and other stuff if you need to. And sometimes you have to be creative and innovative. This is a patient of ours, a gymnast, 9 years old, competitive gymnast. And of course, any of a distraction instrumentation or fusion would end up her career. So we decided to do a posterior tether. This is done with a minimal invasive approach. I expose the plane between multifidus and longissimus, put pedicle screws without exposing the bone. This is done under fluoroscopy. We put in the screws, I put in a big rod first, correct the spine, correct the curve, and then I lock the rod at the apex and cut the remainder of the rod, and I put in a tether to allow the patient to go back to activities, which she did. She returned to competition for 3 months, was participating for about 2-3 years. And of course, 3 years later, when she comes back, you can see how growth can destroy your day, essentially. But luckily, she was old enough, and we ended up fusing her. By this time, she was already done with her gymnast career, essentially. Another case with Pierre-Robin syndrome, growth hormone deficient, very short, multiple joint contractures, MRI is normal. She's about 8 years of age, but she physiologically is much younger. And this is her. And again, the same principle I did. And initially it did not look as impressive, but at 1 year, it really started looking better. And I thought I had conquered the world. But, nothing destroys your day as your own follow-up. And this is her, I think 2 or 3 years later. And again, deformity can worsen with growth. This is how it was, and this is how it is now. It was 3 years afterwards. So I decided to switch it from MIS tether. I switched her to magic rod. Looks good where she's sitting, but notice the severe obliquity. And when she stands, you can see how she's listing to one side. Bought me 2 years, and finally I decided to fuse her. I still have her listing to the side, and she's now booked for an asymmetric PSO at the very bottom. My problem is that she still has severe contraction of the flexion of the hip and knee joint, and to what extent will I correct her lordosis? She also already has a decent amount of lordosis, so she will require multiple surgeries. So lesson learned, early onset scoliosis is like Christmas. It's a gift that keeps on giving, well, each year and every year. But all that is, gold does not need to glitter. I showed you some cases of early onset scoliosis, which I have treated differently with an MIS approach. There's a patient of mine, 10 years old, severe deformity. Mother did not want fusion. So I approached this with an MIS approach. This is fusionless surgery, and I put in a tether up top, again, hoping that it will correct. And I did not feel that need to do anything up top aside from this to prevent kyphosis progression. And this is her 3 years post-op. She has not broken the rod. I learned this from Jürgen Hams many years ago. He showed me 10-year follow-ups. He was doing it without taking the capsule. I do it without exposing the periosteum. Again, minimally invasive. And another kid, similarly, this came to me from California, Rett syndrome, didn't want fusion. And this is her. And I've seen her 3 years post-op. And again, the rod is not broken. They maintain a correction. So probably spontaneous fusion. But the idea here is even if the rod breaks, hopefully I have a relatively flexible spine, which I can still correct and manage it. And, my last patient, this patient, 9-year-old karate kid, severe back pain, weakness in legs. You can see kyphosis, but here's the real deal. The patient has severe deformity, of course, congenital, and you can see the spinal cord has been pancaked from the front and the back. And I'll just play the video. You can see the deformities on the left and the right side. And you can see how the CT myelogram, now the dye is not even seen, and the dye comes back again. So very badly squished. You can see the left and the right side. So I ended up doing a vertical column resection on him. And of course, the kid a year later was back to being a karate green belt again. And I've allowed him to play back. Of course, the story is still to be concluded. This was how he was. And as a result, I got to meet the famous karate kid, Ralph Macchio, at the Mets game. And so all that is gold may not glitter, and all that is all those who wander may not be lost. And all's well that ends well. So thank you. And I hope to see you guys in January. I'm ready for questions.
Shailesh, you're muted, please.
Yeah, great presentation, Dr. Vishal. I think it was not very easy to keep that complications with you and talk about it. It's a very difficult job, and we always know the biggest message which we have learned is delay as much as possible. We just want to know what all are the things which you keep it in mind when you're doing such tether, whether if there is a possibility of early breakage of tether, what is your backup option for a lumbar deformity?
So great question. The tethers will break eventually. Growth is very powerful. The rods will break, forget tethers. But I will still delay it. I'll wait, because the more number of times you go and operate, the more scar down they get, and the bigger the problems or complications will end up with. So I will delay, and if there is a breakage, I'll just continue to watch. If I can buy another year or two, that is what I will do, and then I'll go and maybe fuse the patient permanently. So my job is to try to get away with 1 or 2 surgeries if possible, maximum 3. I don't like going more than 3.
Okay. For benefit of everyone, you seem to be more inclined towards magic rod. What is your experience with growth rods? Whether you really don't want to use them more, or your practice is more of?
So, I mean, we have relatively easy access to Magic Rod. I'm not a great fan of either of the distractions, by the way. I will really select my patient properly. So some of those patients where I just did fusionless instrumented correction, I did not use Magic Rod because I think Magic Rod is just glorified growing rods, except for with a magnet. And that magnet usually works, but not all the time. It has its own complications. It's very bulky. It has skin breakdown. So I like growing rods when the soft tissue coverage is not very good, patient is very small. Those will be my indication, like you saw one of those patients. But again, I will still try to avoid putting these rods early on. I will try to push them away as much as I can. One of my friends, actually, Shyam Kishan, who's also actually from Bombay, will tell you he would, and when I learned from him, he puts the meta cast. I mean, we will cast them if he can. And sometimes it's not easy to do it, cast them and then brace them and buy 3-4 years. And that means 3 or 4 less surgeries for these patients.
Perfect. Any other question from anyone?
Vishal Rupinder. Thank you, sir, for highlighting an important component of surgery, that is complication. In the very first case where the CT-MR was normal and you went in to do a laminectomy from D3 to D7, how did you decide on that?
Well, I did not do laminectomy. I just did a laminotomy. That was the apex of the problem. So we just decided to do just a little bit of laminotomy. I try not to do laminectomies because I'm always worried about kyphosis. But we just opened the ligamentum flavum just to see if there's any epidural clot or anything.
Thank you.
I have a question, if time would allow.
Yeah, last question, sir.
Sure. Vishal, long time back, like when I was in Nottingham, we used to do Luke trolley that John Webb used to propagate. And at least at that time, in my experience, it was doing pretty well. But the patient population were mostly idiopathic the children or early onset scoliosis, which is a different ballgame than syndromic ones. Any experience, anybody practicing?
So that's a great question, Dilip. There is a modern Luke trolley that is being practiced out of France. People have reported that for neuromuscular scoliosis. In the US, it's not as common. I have utilized a similar concept. I just put pedicle screws instead of the trolley. But I don't leave the rods loose. I actually lock it down. I use a thinner rod. I use a cervical spine rod at 4.5, anticipating it will break. And it usually breaks after 2 or 3 years. And then I just go and revise it. I learned this from Jürgen Harms. The advantage of this technique is that I get a correction right away. And as against with the Luke trolley, you may get a great correction, you may not, kind of a thing. But people are using they call it the modern Luke trolley out of France in neuromuscular scoliosis.
So, Dilip, to pick up on your point, there is a group, there is a company that makes an implant called the Trolley, and it is based directly out of that implant that you're talking about, the series that you and I are aware that John Webb was putting together. Right. This is basically like instead of the wire, you have like a band. I've seen a few cases from Sheffield and Nottingham. I haven't done them. I'm not that fond of it. So I haven't seen any reports, so it's difficult to say, but DePuy makes it. It's called the Trolley.
Thanks for the update.
Perfect. Guys, we need to move on to the next topic. And we all are waiting for something which we are hearing for a good some time, and that is awake fusion and awake fusion. Dr. Alok Sharan, we all know Alok as the one of the pioneers in awake fusion surgery, and Dr. Sharan is practicing as a president of Spine and Performance Institute in New Jersey, New York, and he has got a lot of different ideas about how we can reduce the time of surgery, how we can do it in minimal anesthesia, and what people want today, and that is the scare of spine surgery. People want awake fusion, awake surgeries, awake decompressions. So let's hear it from Dr. Alok Sharan about this. Over to you, Alok.
Okay. Thank you very much, Shailesh and Abhay, for the presentation. I'm sorry that I won't be able to join you in January, but I'm happy that I can join all of you virtually. Many of you have heard my talks before previously on awake surgery, and to be honest with you, I'm just amazed at how quickly it's being adopted. I just spoke to a surgeon in Nigeria as well, who's doing advancements, and we've had some visitors come now from England and other places around Europe. So it's clear that something that we're saying about awake surgery is striking a chord with everybody. What I wanted to do today was not necessarily go through why of awake surgery, but just give you some updates on what we're thinking and what we're doing to achieve this rapid recovery. And the title of my talk is Where It Works and Where It Doesn't. And to begin with, what I'd like to do is start with a story. So many of you may know Aaron Rodgers. He's a quarterback. He was drafted or hired by the New York Jets, my hometown. And unfortunately, in the first game of his season, he tore his Achilles tendon, which is tragic because he's such a star quarterback. And this is an injury that typically would knock someone out for the whole season and really end someone's career sometimes. It can really be tragic. But Aaron Rodgers had a minimally invasive procedure, an innovative procedure. He himself is a very holistic person, takes a lot of nutritions and supplements, and he's going to be coming back to the field on December 24th. Now, I don't take care of people like Aaron Rodgers, but it's definitely true that many of our patients now are looking for the rapid recovery, because when they hear stories like these athletes coming back to the field sooner than before, everyone keeps on asking, how can I achieve a rapid recovery after surgery? And so for us now, I always want to be clear about this. Our goal with our Awake program is to help patients achieve that rapid recovery. And the goal, of course, is rapid recovery spine surgery. We've done a tremendous amount of work with ERAS. I think the data is getting clearer and clearer. But ultimately, the goal of what we're trying to do with Awake spine surgery is to help the patients achieve that rapid recovery. Because I think that in the operating room, we're getting really good at being precise in how we do our surgeries, right? We have great navigation tools. We have great robotic tools. But I think what's preventing us from achieving the rapid recovery is the collateral damage that typically occurs from surgery. And these are some of the issues that we're beginning to think about as we develop our program. And when I mean collateral damage, I mean things like in the United States, the opioid addiction. It's very common that after a lumbar fusion, patients are still taking opioids 4 to 6 weeks after surgery. Inactivity, patients aren't moving, they're not walking, they're not exercising. I've talked before about some of the studies that we've done about delirium and how general anesthesia can result in delirium confusion, especially in elderly individual. And then just from a pure experience point of view, after general anesthesia, oftentimes people have nausea and vomiting for a few days, which just leads to just a terrible experience about surgery itself. So what we're trying to do now, as we're looking at developing our program, is to sort of minimize some of the collateral damage of surgery. You know, I've talked before a lot in the past about spinal incision. I think that for another day, we can talk about our protocols that are associated with that. But there's no question that in our data, when you do a lumbar fusion, for example, going from general to spinal, your length of stay decreases by 50%. And that's been validated now by many studies across the country. The paraspinal blocks, i.e. the TLIP block, has been a game changer. Now we're seeing these people that with the paraspinal blocks, people are achieving significant amount of recovery. Sorry, I'm stuck here. I'm sorry. Can you hear me, Shailesh?
Yes, I can hear you. Yeah, hello.
Yes, we can.
We have lost you, Alok.
It appears he's offline now.
We could do some chat until he comes back. Maybe about early onset or about even how many of you in this group has actually done surgery under spinal anesthesia, spine surgery? I have, but out of compulsion. unfit patients. What's been your experience, Rupinder?
Basically, unfit patients, I think more than the surgeon, the anesthetist has to be very good. Because in our hospital, we have only 2-3 people who get us doing this. We've done quite of these unfit people in the spinal also, in epidural also. But when I went to Korea, apart from cervical spine, they did everything under the epidural or spinal.
Anybody else outside India doing or having had an experience of doing a bad lung, guy with a bad lung under spinal?
So I can tell you one situation where a family member had initially an operation at Bombay Hospital, and then he had an early recurrence and cardiopath. So after speaking to some people in the UK, Lester Wilson suggested a guy called Tony Young in Phoenix. And he happened to have a daughter who lived in Phoenix. So they went there. He did a revision microdisc decompression, but he didn't need a TLIF with local and gas, basically, and some sedation. No, we haven't. I haven't done that. But yeah, this is the closest I've come to experiencing that in a family member.
Yeah. I've done a couple of ILDs who are like very motivated to get a lumbar stenosis operated because of disability. And it's come out like it's nothing different, it's just like spinal. Though what Alok is telling us is the whole gamut of, the pre and post, the criteria that he uses. Alok, are you back?
I'm back. I'm so sorry. Do you want me to start again, Abhay, or should I go from here?
You can start from where you were. That's okay.
Okay. I'm so sorry. Okay.
I think how good the anesthetist is, that's also very important, I think.
Okay. Can you see this now?
Yes.
Okay. So what I wanted to talk about was this. So we've clearly, I think, done as much as we can in the operating room in terms of rapid recovery, which means to me spinal anesthesia and using the paraspinal block. From my perspective, as I'm trying to work towards getting more rapid recovery, I don't believe there's much more that we could do in the operating room. You can debate what we use for spinal anesthesia. You can debate what we use for the paraspinal blocks, and that's fine, but those are marginal improvements. So as we continue our rapid recovery, what I'm trying to do is, like Abhay was referring to earlier, which is taking on a more holistic approach, looking at things beforehand. So for example, we're trying to optimize the patients now prior to going to surgery. We know pretty clearly the value of nutrition, right? There's been more than enough data out there on all this. If you look at the literature from the joint replacement world, there's a company here in the US called Mend. They've done some really good, elegant studies around this. And they show that with their supplement protocol, they're actually able to preserve muscle and improve return to function after surgery. That's using a combination of amino acids and different vitamins. And in their literature, for patients who undergo total knee replacements, those who do supplements prior to surgery achieve higher activity levels much sooner than patients who don't. So in using that information now, prior to surgery, we're trying to optimize our patients nutritionally. So we do an amino acid IV infusion prior to surgery, and then we do a 4-week. At 4 weeks, we do a post-op Myers cocktail, which is a bunch of different vitamins, but also has some anti-inflammatory component to it. So at this point now, we're trying to optimize the patients nutritionally. That's my main focus. The other thing that we're doing now is our biomechanical assessments. You may have heard about these computer vision tools where essentially now an AI program can look at you and start looking at your mechanics. Now, in the exercise world, this is a very common thing. But what we've noticed is that after surgery, especially for the patients who have spondylolisthesis, for example, their biomechanics are off. And that if you don't try to optimize their biomechanics, they lead to more long-term problems. I have an athletic trainer in my office, and what she does is we have them sit in front of our iPad, where we can basically look at their biomechanics, and then we give them a whole series of exercise videos. And then we have a program that while they're at home doing their exercise videos, we can sort of watch them to make sure we're doing all that. So for this point now, you can see that what we're trying to do is a few things. We're trying to optimize them biomechanically, both pre and post surgery. We're trying to optimize them nutritionally with our IV infusions, both before and after surgery. In the operating room, of course, we do minimally invasive surgery, And to me, it doesn't make a difference in my experience if you do MIS versus endoscope. I think that at the end, the anesthesia is the more important aspect. Of course, we use the isobaric spinal anesthesia. We use the paraspinal blocks. And then afterwards, we're trying to minimize how much narcotics we use. The goal, of course, is to make sure that they feel like they're not having surgery. At this point now, we're able to do this for any lumbar surgery that takes less than 3 hours, 1-2 level fusions, multi-laminectomies. This is what we do as a routine basis now. What we're trying to do now, and this is with some of my colleagues here in the US, is what we want to try to do now is define what rapid recovery in spine surgery means. At a minimum, it means being able to do a lumbar spine surgery and go home within 4 hours. That's number one. We want to minimize how much pain they have so that they require minimal narcotics. And then we want to get them back to work sooner and back to function quicker. So we are trying to define now what exactly it means when we say what rapid recovery is in spine surgery. Just some anecdotes over here. We just operated on a foot and ankle surgeon. About a week after his surgery, he was back to doing his own surgeries on patients. We took care of a dentist again 1 week later. And so these are the different things that we're looking at in terms of returning to function. Similar to Aaron Rodgers coming back to playing sports, we're trying to look at a patient level, what does it mean to be able to return to function quicker? And then you may have seen this video in the past. This is one of my favorites. Feeling good, like I should. Around the neighborhood. Feeling black. She's one of my favorite patients with this video over here. But that's what we're trying to essentially achieve over here. So I hope that was helpful for you, just giving you an update on where we stand and what we're trying to do.
That's an excellent talk, Dr. Saran. So I always had this question regarding awake spine surgery. You know, it's a non-physiological position. How often do you have issues where patient get uncomfortable and start moving or, you know, complaining post-op that they were not comfortable during the entire experience?
Yeah, that's a great question. And so I'll tell you this, my understanding is that it may be non-physiological because they're prone, but actually, to be honest with you, it's more physiologic for the patient. So what I mean by that is this: if you have a 75-year-old female, they often have rotator cuff problems, shoulder problems. And when you put them on the table, you may put them like this because this is the way you think they should be. But in fact, actually, most of the times they have to cross over. So what we find is actually the patients are actually able to position themselves in a very comfortable position that can last for a couple hours. It's very rare that they actually have to move. At anything, they may move their face a little bit. But in terms of their upper chest, as long as you have proper padding, it's never been an issue for us that they want to move.
All right. And, you know, sometimes just if at all we have some complications in drop, like a CSF leak or uncontrolled epidural bleeding, do you feel that managing them when the patients are under general anesthesia with better controls over the pressures is easier, or you've never found any difference?
No, it's another good question, because I just had a durotomy the other day with a patient who was awake. So first of all, you have to make sure you're dosed properly. But in fact, actually, with the durotomy, it was honestly just like we normally routinely do. Now, what's interesting actually is this: when you want to check your durotomy repair, you do the Valsalva maneuver and you get a certain amount of pressure. But in fact, actually now, when we do our durotomy repairs, we ask the patients to do a Valsalva themselves. I believe actually that's actually a better test of your durotomy repair, because the patients are able to generate more pressure, intra-abdominal pressure, than if you did it under general anesthesia.
Great. Yeah, I think this is a very good study, because it's going to help a lot of places where you know, the infrastructure is not good and there are problems with general anesthesia. So it has a great implication in the society. Do we have any other questions for Dr. Saran?
Yeah.
Dr. Saran, good evening, Dr. Chahal here. Was there any incidents where you need to convert the spinal into a general anesthesia?
Yeah, that's a great question. So knock on wood, we have not had to convert from spinal to general. And the reason why is because first of all, we won't do it on somebody who we don't think can tolerate it. That's number one. Second of all, if there's any issues after we give the spinal, we won't proceed with surgery. I was just reviewing another paper out of Boston too, and they had the same kind of experience. They've never had to intubate. The truth is that you should have your criteria on who you're going to do spinal for. If I'm doing like a big revision surgery, I do general anesthesia. So I think that as you become more comfortable with your predictability, you shouldn't have to convert to general anesthesia.
Yeah, Alok, a great talk. We have heard a couple of times about this, and when we discuss about this awake fusion, people say, why you want to take that chance of awake fusion? Better give a good general anesthesia and get away, patients are away. What's your experience? You've been a general anesthesia guy for donkey's years, and now you are talking about awake. What is your personal feeling and why you really want to do it, why you want to promote it?
So, in my point of view, the ideal scenario is that someone has surgery and the next day you should be able to see them and not tell that they had spine surgery. Because if you can do that, then you're not disrupting their life. You're taking care of their pain and you're not disrupting their life. That's what the goal is, right? In hand surgery, you can probably see that, and some very good knee surgeons perhaps, but certainly in hand surgery. So why should spine surgery disrupt someone's life so much? And so you can see that what I'm trying to do is say, okay, what's the collateral damage? First, it was the general anesthesia issues, then this, and you can see how I'm basically just chipping away at all those issues because, you know, the fact that I can operate on somebody, a foot and ankle doctor, and a week later he's back to doing surgery again, is to me is that. And so what I keep on thinking is, okay, what prevented him from going back to work the next day? And what we try to do is understand, like for in his particular situation, he had some pain and, you know, so the different things. And so what I'm doing is I'm chipping away at the factors that are preventing people from returning to function soon. And then I'm optimizing from there. And so with the IV vitamins infusions, you'll see that going into surgery, many people are tired, they're fatigued, they're in pain, they're inactive. Okay, if you give them the IV amino acids, it's an energy booster and it builds up muscle mass. And I can tell you empirically, we don't know the data yet, but empirically, they come into surgery with a lot more energy than those who don't. So that means that their recovery is going to be better afterwards. So I've said that I've hit a wall in terms of what I could do in the operating room, in terms of optimization. Now I'm climbing prior to the operating room.
Yeah, perfect, Alok, understood. Normal to near normal, that's what we want at a very less time. And that's where the world will go tomorrow. Perfect.
Yeah.
Thank you. I think we need to move on to the next presentation. Priyank.
I would like to introduce our next speaker, Dr. Dilip Sengupta. After having graduated from the University of Calcutta, he has had immense training in the Department of Neurosurgery and Orthopedic Spine Surgeries in both the UK and the US. He's had multiple publications and book chapters, more than 50 of them, and has been a mentor to a lot of people in the ASSI. Sir, it's my privilege to invite you for your talk on motion preservation.
Thank you very much. Since I left the country sometime around 1995 and came to Nottingham, the big emphasis was on fusion for previous 30 years. In the non-fusion, both in terms of disc replacement or dynamic stabilization was just coming up at that time and drawn my attention. And throughout my career abroad, I had keen interest in visiting most of the stalwarts who have introduced, propagated, and been the teacher in this field. And finally, in 2015, this book came out, Dynamic Reconstruction of the Spine. This was the second edition. And that covers the entire topic of non-fusion or motion preservation techniques. And it became very popular. 2 years down the road, it got translated into Spanish. And about a couple of years back, it has also again been translated into Chinese language. So that just tells you the interest of the people. But my own experience is that much of these, whether pedicle screw-based dynamic stabilization or disc replacement or other form of motion preservation technology, their kind of enthusiasm dying out as we encounter more and more problems. And I'll share my experience as I see it. Now, why you at all think of motion preservation? Well, fusion works great in terms of achieving your goal. You can stabilize the spine, you can achieve a good pain resolution, but this is not infrequent experience even after achieving good outcome. And we think that if we would have preserved the motion, perhaps that would have solved it. And that gave rise to the thought of motion preservation with the disc replacement in the first place. And this is one of the earliest disc that has been used for a good length of time. This was by Acromed, and this is Arthur Stafey. And I had my mustache and I was a young man, like many of you guys. And this was a very successful disc prosthesis. Robert Fraser in Adelaide has used it extensively with a very, very good outcome. But unfortunately, you do not even see this anymore because the flexible component between the two metal plates, that is rubber. And as you know, over time, the rubber gets oxidized and disintegrates like powder. And almost 100% of these cases in 5+ years' time do fall apart with complication. And this device is no longer in the market. But this had all the good qualities that a prosthetic disc should have, like it had axial shock absorption, it had multiple axis of motion, it could adapt to the motion pattern that your lumbar motion segment would require. Everything you asked for from a very good lumbar prosthesis, this one had, except for the fact that the component that is giving all those good effects, that disintegrates as it becomes chemically changed. The longest lasting disc prosthesis were by these, as is by Charité disc prosthesis by Karin Buttner-Jans of former East Germany, and a few years later, the Pro Disc by Thierry Mornay from France. And those were very successful for a good length of time. Unfortunately, much of these are no longer in the market, but the Charité disc prosthesis was bought by the American companies for $30 million. And about a year later, the Pro Disc was bought by another competing American company for $300 million. And these were happening around year 2000 till 2003. And I had interaction very closely with their inventor and also the other people who were using it more frequently and have gone into the depth of it. While the good results are always publicized a lot more, but the problems are not infrequent. You get good result with one segment, but the moment you step forward to do another segment, then comes a problem, not just the segment that is moving, but how it is moving in comparison to the other segment. And the problems are not infrequent. And the size of the disc prosthesis, it can again dig into the bone and loses its capacity, and it needs some form of stabilization. And it is not unique to Charité. The same thing can happen even with the Pro Disc. So the failures were not infrequent and not very easy to tackle, like this one. While it is just pain or motion is not preserved, it's not that big of a deal. But when it causes damage, that could be life-threatening damage, and then it becomes a nightmare. Like this is from one article from Netherlands, that the disc prosthesis slipped out, and a repeat visit to that same area surgically becomes a nightmare. And one of the very popular publication from Van Oys, and he is from Netherlands, he collected 27 patients that he had to operate again after having disc replacement and to do salvage. Now, that is not the end of story. Even without any catastrophic complication, your intention to preserve motion may not remain successful for a long time, and oftentimes they fuse. And this is one of the examples that it has got a solid fusion, and not unique to Charité. It also happens to the other popular prostheses like Pro Disc. And this led to a very important article by Paul McAfee, who in fact classified the different grades of fusion that can happen. It's actually called different grades of heterotopic ossification, ultimately leading to a solid fusion that can happen around disc prosthesis. Now, Rudy Bertagnolli, he did not devise anything by himself, but he is one of the very strong proponent of using and propagating prosthetic disc replacement. But I will share one of his enthusiastic case here. Like he wanted to preserve motion, and in a 360 fashion, not just the anterior disc, replacement, but also with the dynamic stabilization posteriorly, like from 360 fixation and preserving motion. But this happened few years. The patient was osteopenic, as you can see, that one of the bone fractured and patient developed a kyphotic deformity with pain. It did not dampen his enthusiasm. He did an anterior correction to correct the kyphosis, but posteriorly, rather than fixing it with screw and rod, he put a Coflex or another motion preserving device. Didn't survive too long, and this was the final result that he did. He had to correct it with the posterior pedicle screws and rods, but still did not address the bottom end. And this is how the patient came to us with the kyphotic posture above and terrible pain everywhere. And I had the opportunity to open it up. As you can see, motion preservation device there, the flexible rod. And this is also connecting with a device that we didn't even have any idea what the device looked like, and a Coflex over here. And the proximal junction, patient developed kyphotic deformity with fracture. So we converted everything into fusion without removing the Coflex. And I was very lucky that we didn't have to do anything further. We did not remove anything from the front that remained over there without causing any more serious problem. Now, I participated in evaluating many of the devices, and this is in ProDisc, and I was in Detroit, Michigan, and in our biomechanics lab, we tested many of those, and we tried to find out which one may be superior, which one may be, what could be the cause of failure. We did the motion tracking, as you can see here, normal versus after disc replacement. Is the motion pattern ideal? Can we predict any failure? Or how we can improve on it? And this is, we tried like fixed instant axis of rotation, similar to ProDisc, and the fixed IAR with the metal on metal rather than metal on plastic. And what about variable IAR, like instant axis of rotation can change as the plastic component can move forward and backward. And that is the principle of the more modern disc like Active L, which is now in the market, where the plastic component can slide forward, backward, and giving some range of motion of the instant axis, so that the rest of the motion segment, like the facet joints, doesn't get stressed out compared to ProDisc or the other older generation of disc prosthesis. Other newer ideas of this prosthesis is that incorporation of the shock absorption, which is not there in the metal on metal or metal on plastic, with a gel in the middle and then encased with fabric and with the metal backing. That is the principles of M6L. And all these components also have a cervical disc replacement, which is becoming more and more popular, not because it significantly improves the function compared to a traditional fusion, but it is much less encountered with complication. But this is the outcome of the lumbar disc prosthesis. You can see how many devices are out of market now, whether you call it Kineflex, MobiDisc, ProDisc, not ProDisc is still in the market, Charité or InMotion of the further development of Triumph, and all these disc prostheses are currently taken off the market. If you want to do a lumbar disc prosthesis, the Active L is still there, approved by FDA, and ProDisc L is still available to be, but although it is not being used very frequently. The InMotion Dupuis spine, although it is approved, but it has been taken off the market, so you cannot find anything there. As I told you, the cervical disc replacement, it does not, at least in my experience, improve the function much, but because the complications are rare, they are being used more and more frequently. But when it complicates, it becomes little more of a problem than if you try to do a traditional ACDF or fusion. The loss of motion by solid bone formation or heterotopic ossification is still a reasonably big challenge in cervical spine. It is more frequent than in lumbar spine. So this gives the market data that during last 5 years, the enthusiasm of motion preservation has stamped down, although the market researchers say that that is not end of it. As the newer designs coming up, that market is going to go up more rapidly for the cervical than the lumbar spine motion preservation devices. The next topic could be the nucleus replacement, that if not the disc replacement, big surgery, can we just replace the jelly part of the nucleus? And this is one of the device designed for improving the height of the disc. And after discectomy, you can insert it with a minimally invasive approach. And Charlie Ray propagated this. And for some time, it was very popular. But the problem was that oftentimes after few years of movement, those devices would back out or come out like a herniated disc itself, and you have to take it out. And even if it stays in place, it can cause problem of erosion of the end plate with recurrence of pain. People have tried in different ways of doing the minimally invasive, and this is another ingenious way of inserting something that goes like a coil and replace the jelly part of it. But to my knowledge, none of these techniques are surviving in these days or being enthusiastic. The other form of motion preservation from posterior aspect is interspinal distraction. Biomechanically, it can open up the foramen or the stenosis with a minimally invasive approach. And because the surgery is simple, so it became very popular very quickly. But because it was a newer kind of device, the very first device, X-Stop, that required a prospective randomized controlled study before it got FDA approved. And Dr. Zuckerman was the pioneer in doing that. And nowadays, almost every single spine implant companies do have one or other interspinous distraction devices, of which Coflex is most frequently being used. I've also used it some. The indications are when the spinal stenosis need to be addressed at the foramen with minimally invasive, particularly in the elderly person who may not be good candidate for an open decompression fusion, etc. Unfortunately, the most suitable indications, the elderly population do not have strong bone, and the spinous process itself may fail, and that causes failure of the entire system. That brings us to the enthusiasm of medical screw-based posterior dynamic stabilization. The first of its kind was done in 1992 by Henry Graf in France, and this is the Graf device itself. And I had great enthusiasm because in Nottingham they were using it, where I went for training with my initial training on spine surgery after moving abroad. And I raised a question that if you apply a ligament like this, it will cause constriction of the nerve root foramen. So why don't you put a fulcrum in front? And Professor Mulholland then renamed called fulcrum assisted soft stabilization, or FASS or FAS system. And that FAS was never being implanted in living person, but that concept gave me my PhD equivalent degree. But in Nottingham, we were using Graf ligament, and whether you believe it or not, despite the problem of this foraminal stenosis it can cause, overall patient satisfaction was not too bad. The one in the upper one in 2011 publication, 2001 publication was that the long-term follow-up is not very favorable, but in 2003 publication it says the long-term follow-up is at least as good as the fusion, if not little better. But to address the problem that it can cause the foraminal stenosis, the DESI was coined. It was just a modification of Graf ligament that you put a plastic spacer, and that was developed by Gilles Dubois of France. And that has been very widely used in US. The transition was a modification of that. While DESI was very successful from its business point of view, but the failures were not uncommon. And the most difficult part was that to combine it with fusion, because the pedicle screws are very different. That can take the DESI device, but cannot take a fusion rod. So the Globus Medical, and I was part of the team developing it, that we could use a fixed rod and a flexible system like DESI in the same alignment, and at all the segments you can use just the regular pedicle screws. And for a short duration it was quite successful, but then our experience, as we found the long-term follow-up, the failures are not infrequent. And here it shows that if you have to do 3 pedicle screws with the combination of fusion plus DESI device, with the DESI original screw design, it will be very different. But with transition, technically it is easier. But the failures are not infrequent, even in the hands of the originator. This is Gilles Dubois' paper, that screw loosening or screw failure are almost 11%. But the independent reviewer says it is even more. It can be 17 or 20%. And if you wait a little longer, you see it happens even more frequently. Now, transition made much of the technical problem away from application of DESI, but it was not free from any of the complications of DESI. And as we have seen in the long-term follow-up, that it can fall apart with the screw breakage and the segment failure, and you have to finally take it out. And as DESI has gotten off the market, so also is transition. The question is, why it fails? Why such a high failure rate of screw loosening or screw breakage? And we looked into it in our lab multiple times. It is because as you apply the device, this becomes the center of rotation. And this is in a normal segment. And this is a motion characteristic compared to one pedicle screw. If it is fixed, how the other pedicle screw moves. And we tested that motion tracking. That is the normal segment motion tracking before you do any stabilization. But once you stabilize, the motion tracking becomes like this. And particularly the posterior part, when in extension, this plastic spacer becomes like a hindrance, and that causes excessive stress at the screw bone junction, leading to either screw loosening or screw breakage. The same device remains very successful for other applications. Like here, we have used transition to prevent proximal junctional failure, and it works very good because there is not a whole lot of motion that can cause its early failure when you apply it in the lumbar spine. There are many other similar motion preserving devices. This is by one of the originator, Dr. Moon, and this is like a spring, traditional spring, and he used it in Korea, which has not been used in US. There are many other devices, of which the second one from here is from Professor Manohar Punjabi, called Stabilimax. Once again, not anymore available. This is one of the flexible rod. There are many other flexible rods too, and that were also introduced, taken off the market. This is Isobar TTL, still available, but not many components out there. And this is another device. But once again, most of these are seeing failure and taken off the market. While I was observing all these, I didn't remain much silent. So I devised this one. It's called DSS, or it is actually no name. I just called it Dynamic Stabilization System. And it has never been used in US, but one of those early prototypes were used in Brazil by Luis Pimenta. This is Dr. Pimenta, and using it in a minimally invasive way that you can insert it without doing any fusion. And this was the first patient who had back pain, and this was the first implanted in human being, the DSS system. The initial results were very good. And Dr. Pimenta, who were also doing other form of motion preservation, he used it to salvage when the disc prosthesis fails or the nucleus replacement fails, etc.
Sir, sorry to interrupt. Can we start summarizing? We are running out of time.
So I think I'm on the last slide. So the overall results were good, but the long-term outcome of the DESI, which was the longest active pedicle screw-based dynamic stabilization system, that unfortunately was rejected after the introduction of it for a motion preserving device, and that was the end of story of dynamic stabilization devices, that most of the devices are off the market and no new devices are being introduced anymore. Thank you very much for your time.
Yeah, thank you, Dilip sir, for an extensive, detailed motion preservation historical aspect and what's happening today. There was something called as the Spine Arthroplasty Society, and I have presented my work in 2010 in New Orleans, US. And I think that time was the peak of this. Thai Prism from England, Rudy Bertognoli and Paul McAfee, they were doing a lot of posterior facet replacement and anterior lumbar disc and multi-level cervicals also. But I think there is a lot of rationale for this. Selection of patient is very, very important. The device for intervertebral assisted motion was there, DM, which was quite popular those days in the Western world. But I think still people are working on it. Any questions you want to ask Professor Sengupta, or we move on to the next topic?
Sir, how difficult is it for revising those failed discs practically? Is it a nightmare?
Disc replacement, if you have to go in again, it is a true nightmare. In US, Paul McAfee has more extensive experience, and the one from Netherlands, Van Oys, he had extensive experience, but they're really nightmare. The modern suggestion is that unless it is really causing some problem to the infravena cava or aorta, then leave it alone, just fix it from the back, and the outcome is same. Whether you leave the device in or you remove the device and then try to salvage, overall outcome is same. So unless it is causing danger, don't try to do anything in front.
Excellent.
Yeah, no, Srivastava.
Yeah, a very good evening, Dr. Dilip Sengupta.
Yes, sir. So
very
nice
good morning to you there, but here it is a good evening. So
Yes.
I just wanted to ask one question. In US, when I visited, I had seen that ACDF at lower level and proximal side, they started using this hybrid, means they started using the disc replacement. So what was the outcome? What is the outcome of that?
I actually briefly mentioned that the outcome is no different compared to fusion. Whether you fuse 5 level or 3 level, or you do fusion at 2 level and then disc replacement in the adjacent segment, overall outcome is same. You have seen your own patients that you have done 4 level cervical fusion and you ask them to move. The majority of the movement comes from the top 2 levels, C0, C1 and C1, C2. And majority of the disc replaced segments hardly moves because cervical spine tend to fuse so quickly and it hardly preserves any motion. So the overall outcome is same. However, the popularity of the cervical disc replacement is that it is easy to do. It's in fact more simpler than doing an ACDF, and the complications are never catastrophic. And you can revise it if you have to, but you rarely need to, because if there is any problem, it just fuses on its own.
Thanks.
So those who believe in it, they feel that at least 5 to 6 years or 7 years of motion you can give it to the particular patient before it fuses. So that's the belief. Therefore, people still are doing cervical disc replacements.
Thank you so much.
It's easy to sell that idea, and that's the reason for survival. But
Yeah.
is there any true need for it? I doubt. I get a royalty for the cervical disc replacement that I participated in developing, but I never use it.
Perfect. I think.
Thank you so much, sir. Thank you so much for your insight. We'll move on to the next speaker. I would like to introduce Mr. Jwalan Mehta. Mr. Mehta has passed from GS Medical here in Mumbai and is now a consultant in Royal Orthopaedic Hospital at Birmingham. He's an extensive work in the field of deformity correction, is actively involved with the Scoliosis Research Society, and has multiple publications in the same field. He also has several research grants in the same field, and I would like him to share his experience on AIS. In fact, I had a privilege of working with him back in 2014, and I can vouch for his work. Sir, if you may share your experience.
Thank you very much. Can you hear me?
Yes, we can.
Thanks, Priyank. So thank you for inviting me for this. My charge today is to talk about how I deal with a stiff adolescent idiopathic curve. These are my disclosures. So for me, knowing whether a curve is stiff or not starts with clinical assessment. So things like pelvic shoulder level is important. Left shoulder up, the wrong shoulder up is always a problem. Knowing whether it's a big rib hump, truncal shift is useful to know. But from my practice point of view, one of the things I find is that ethnicity is really important. Whilst most patients tend to be Caucasian, if you do see a Afro-Caribbean or any other ethnicity, they tend to be a lot stiffer much earlier. The other very important aspect to look for is clinically to assess whether or not that this is going to progress. Now, we know what the growth charts are. We know where the growth spurts are. It's different in boys and girls. Onset of periods is a very useful surrogate identifier of when they're likely to hit the adolescent growth spurt, but also a relative height between the siblings. So with the father and son and mother and daughter, that kind of thing are useful. Knowing the heights of older siblings is also quite handy. And then coming to radiographs, it's useful to know what we are actually dealing with, particularly when we are thinking of a stiff curve. Looking at curves below and above to know whether there are any significant compensatory factors, shoulders and pelvis, particularly to know whether there's any associated limb length inequality, but also looking at apical discs. So flexibility assessments is more important than anything in identifying a stiff curve. So you can have a large curve, but it may not be stiff. You can have a small curve or rather a moderate curve, which may be stiff. So it's really important to identify between these. And this is an example of a very badly done side bender. So if you have a badly done side bender, it doesn't really give you an idea. And in that situation, I think a traction X-ray, we do it under GA, but it doesn't have to be done under GA. That we find pretty handy. So when we talk of stiff curves, we're talking about the personality of the curve. We're talking about not just the magnitude, but how flexible they are. And based on this, surgically, what I tend to identify is releases, whether we need releases and what correction techniques we should use. And that really helps me work out how best we should deal with this patient. Common release options, you have posterior release, you have the typical workhorse is ponte osteotomies, but we also do a lot of anterior surgery in my unit here. And in terms of a big stiff curve, apical discectomies can sometimes be helpful. So now we'll just look at some of these aspects. And looking at ponte is a really a good workhorse in terms of the osteotomies. It requires a flexible anterior column. If you have a big curve, it's really important to identify that there's no hemi hiding in the apex or that you don't have any other secondary features. You can get good corrections, 5 to 10 degrees per level. Usually I tend to do it at multiple levels. It is quite safe. It doesn't add much to the blood loss. And once you start doing them, it is a very useful technique to have in your armamentarium. This is just some information from literature showing that with increasing releases, as a part of the ponte osteotomy procedure, you get increasing mobility. So that's really important. This is a very different osteotomy from Smith-Peterson. And I've actually heard Professor Ponte, who unfortunately passed away not long ago, speak on many occasions. And his osteotomy is very unique because although it is safe, it also, we need to identify the biomechanical aspects. The center of rotation of this osteotomy is within the vertebral body. And it's very different from a Smith-Peterson osteotomy is more of opening a wedge, more uncontrolled, anterior column lengthening, whereas a ponte osteotomy properly performed is much better. This is an example of how we do it. We use broad osteotomes. It is quite safe to do it, although it looks a bit hairy. And the chevron cuts that you do at multiple levels sequentially, and then you can do your correction. This is an example of Sherman's, but we can do something similar in idiopathic, differentially between the right and the left side, based on the convexity, etc. We typically do multiple pontes, and as you can see, with multiple pontes, we get an increasing flexibility and increasing correction in different planes. And as we can see in this picture, we have multiple ponte osteotomies that we've done in preparation for the next correction. This is an example of a 16-year-old with 72-degree curve, bending down to 41. With 4 ponties, we've got a reasonably good correction, and the patient is happy. Another example, 70 bending down to 50, main thoracic, 60 bending down to 50. Again, not very flexible, but not large curves, I would say. But yet we managed to get 3 thoracic, 4 lumbar ponties, and we've got a good correction. Anterior releases are also very useful. And if you were to look at these in turn, usually we tend to do these in over 80-degree curves. Traction X-ray helps identify whether you need to do it or whether you can get away with just a posterior. We have to assess the apical discs. If you have big chunky discs, then it's going to be helpful. If they're not very big, then it's not going to be of help. Using various techniques to count, to identify which levels we need to perform. We'll go into that in a little more detail. There are some anesthetic considerations. TIVA is a standard one. The anesthetists have to be informed beforehand so they can put in a bronchial blocker, selectively ventilating one lung as against the other so that it doesn't come in our way. Spinal cord monitoring is really useful. We do soft clamping of all the segmentals for about 10 minutes before we tie them off. Mainly, more so in the left thoracic lumbar curves, but we do it at all levels. Positioning is really good for anterior releases to identify, break the table, appropriate pressure padding. I'm not going to go through it in detail, but this is a topic in itself. Choice of levels, usually we count the ribs both sides, go for 1 level above if you are releasing, 2 levels above for instrumentation. But again, this is not set in stone because in younger patients, you can get away with either double thoracotomy or osteotomy of that adjacent level, or even it's quite flexible and we can just open up a bit more and we can get to the levels we need to. Segmentals is really important to identify these soft clamp for 10 minutes. We can work without tying them, but they tend to bleed a little more. But in terms of the technique of the release, it's really important. Rib resection is really important. Annulotomy, nucleectomy, ALL resection. We've got to get the disc out completely, get the cartilaginous end plate, go to the back, go to the far side, and then you can see once you've done the unbreaking the table, leveling out the table, that the discs really compress down. And that, for me, is a really good anterior release. Correction techniques, various ways people do it. I would just clump these as thinking of cantilever, derotation, and compression distraction. Cantilever is the most basic one, where you fix one end and then gradually engage the rods going downwards. This allows for passive lengthening, segmental reduction, and you've got to control the apical rotation and rib hump. It doesn't happen automatically. This is an 18-year-old with 80-degree curve. We managed to get multiple ponties to get a correction, but the apex there's still a bit of a rib hump there, which is better than before, so the patient is happy, but it's something that we've got to keep in mind. Sook's technique of derotating with the what we call strap-ons and pushing down on the rib hump while lifting up the concavity is really important. There are other techniques that we can do: compression distraction to level the screws, compression increase in lordosis. It's more a fine-tuning technique. It's really important to identify the sequence of staging and releases. Sometimes we need to do one, sometimes the other, sometimes none, and it's all built into our practice. We've also got to think of, if you're doing multiple procedures, whether we want to stage them or do it all on the same day. Choice of implants, for me, usually a uniplanar screw works best. We try to have as many implants as we can, top and bottom, and a few thrown in over the apex. Implant density doesn't have to be that, it's not that critical. We tend to use soft hooks for soft landing, but that's not absolutely mandatory. You can go for screws all the way. This is a 100-degree curve that was bending down to 44, but we had very dysmorphic concave pedicles. And this is a recent publication that I've done some work with the guys in AIMS. We looked at pedicle asymmetry and dysmorphism, and it's really important to identify these beforehand, especially in big curves, not necessarily big curves, but more in stiff curves. So what we've said is that the asymmetry and dysmorphism are more linked to the rotation rather than curve magnitude. And then, of course, we have other options such as the stiffer options like stiffer rods, rails, etc. And then I use a dual rod strategy where we have a convex, flatter rod, concave, harder, and a more overbent rod. And sometimes I use these longer devices to try and capture them all so that we get a better correction of the curve. This is one such patient, 93-degree curve, bending down to 76, and we've got a reasonably good correction, 4-level anterior release and apical pontes. Afro-Caribbean, 14-year-old, very stiff, 4-level anterior and multiple pontes, much smaller rib hump. Again, 120-degree curve, bending down to 95. This needed a lot of work, so we've done a 5-level anterior release, multiple apical pontes. And sometimes with these, you've got to think of staging it, but not always. It could be a long day at work. Another example where we've done a diaphragmatic release, the thoracolumbar curve was bigger in the worst of the two, so we've worked on that more from the anterior, and then we've done a posterior pontes. This is a more recent patient that we've managed to save a level by doing a lot of thoracal upper lumbar pontes rather than doing an anterior release in this patient, because she didn't want it. So there are other options that we can use. There's a halofemoral traction. We have the anterior release with a halo gravity traction, or we can have VCR, PVCR, which are a little more aggressive. So looking at tractions, just very briefly, it can help. In intraoperative group, we can, what Lewis as well as Lenke's group have showed, that it can improve your curve correction. It can improve your screw insertion when you go in from the back, but it is quite a labor intensive for the patients and for the nursing staff. This is something we've done recently, halo gravity. So we do an anterior release, stage it 4 to 6 weeks in a halo. You need the patient either in a bed or ambulant in a wheelchair or on a frame. And then we prepare the family and patients beforehand. And we can really work on some really big curves. This child, this kid actually, a male, he progressed quite considerably through the COVID period, and we couldn't really do much about it. And that was a curve at the at the start when we finally got to operate on him. So we did our anterior release, we did our halo, and I think given the situation, we've got a reasonably good correction. This is another one that we've managed to get a good damage limiting correction, much better than before. A happier patient, but some of these patients can be really difficult to deal with. Just to recap, spinal cord monitoring is really important in stiff curves, because especially when you want to do more work, reviewing the MRI is important. Soft clamping, if you're doing an anterior release, maintain your blood loss, temperature, map, and your BIS. Respond to any significant changes on spinal cord monitoring. It's really important to stage or close up and come back another day if required, but don't just accept it, because you don't want a very great correction with a neurologic deficit. So you've got to think of all these things. Just to recap, when I would do an anterior release, depends on the flexibility, depends on how much correction I want. It is very safe, but you've got to talk to patients and family beforehand. And of course, you've got to know how to do it well. Visit a center if you need to. There are a few centers still doing them, so it's really useful. Managing expectations is really helpful. I cannot overstress the need for staging and raising the expectations for correction. The other important thing here is, in terms of the 5 tips for dealing with a stiff curve: push the boundaries within safe limits. It's really important to preempt and discuss with the patient. So we tell all the girls, we can make you a princess, but not a queen. We want to make you better, but it may not be perfect, especially in stiff curves. Plan releases beforehand, especially if it's anterior, because that's going to be 2 procedures rather than 1. Choose your implants wisely. Make sure you're happy with them. And finally, balance is the key. Don't push the wrong shoulder up. Thank you.
Great talk and excellent presentation, and cases which you shown, Dr. Jalant. I think it's not easy to do this kind of challenging deformities and stiff curves. Just want to ask, any special tip for shoulder imbalance?
So shoulder imbalance is a very difficult thing, A, to assess, and B, to control. So what I have found is, the 2 things that you got to keep in mind is, when you have a proximal thoracic curve, your concavity of your proximal thoracic curve, you'll have difficult pedicles. So be prepared to use hooks, either a combination of laminar hooks or even transverse process hooks. We tend to pull down on the shoulder and lock it in place. despite all that, sometimes you tend to lose the shoulder position. But what I have found is that as long as they are in good balance, you've gone long enough that they're overall good in just the shoulder, you might get away with it. Occasionally, I've got one patient that I've got to shorten the rods on where the screw is in, out, in, because it was a very dysplastic pedicle, and it's causing a lot of pain because the screw is in the costovertebral joint, and I've got to shorten the screw. It's not very common, but it's something you got to think of. So that's one of the very difficult ones to deal with, and you've got to just lower the expectations of the patient just to keep the pressure off you.
Any experience with ultrasonic scalpel for doing the osteotomies? Probably.
I have one or two colleagues who like to do it. I don't. I'm a more, like the big sharp osteotomes. The broader, the better. You use those. You can see people around you, especially if they are visiting, cringe and wonder whether I'm going to go through the cord. But believe me, you won't if you have the really broad osteotomes, and you got to see it to believe it.
Any experience with navigation 3D at the apical levels so that you can get better derotation?
So yes, I mean it's more to do with getting the screws in than getting a derotation. I think the derotation issue I can deal with much better with the dual rod reduction technique. So softer, hard on the convex side, harder on the concave side, a rail preferably, things like that. For navigation, I've been asking my hospital a lot. They've given me some kind of a PlayStation type navigation, which I haven't used, but I'm hoping that we'll get something better. There are some really good systems on the market, and I'm trialing some of them before we sign up to them. So there's one called 7D which uses the Tesla type cameras linked to your intraoperative, preoperative CT scans. And then there's an Aero. So yeah, there are some in the market. Don't believe everything that you see. Just use it first. That's what I would say.
Perfect. Any other question, Mehta?
I had a couple of questions. So, sir, with these newer implants and cobalt chrome rods and higher implant density, do you feel that the requirement of anterior releases is going down?
I don't think so. I think there are two things here. One is creating flexibility in your spine. So if you have a stiff curve, I would say you shouldn't rely entirely on screws, because if intraoperatively you haven't done any releases and you start putting in your rods and screws start pulling out, then you have only yourself to blame. What I would say is you do your anterior releases first, or not just anterior, any releases that you want to do, plan it beforehand, do that first, and then you can use the same things with the implants that you do, have higher implant density, have harder rods, etc. What you will really do is you'll take the stress off your screw. So your chances of screw plowing will be less, and you'll get a better correction. So I would say don't compromise on releases. Do the releases that you safely can, but use the implants the way you like to. So stay in your comfort zone.
Okay.
Concave rod first or convex rod first?
Sorry?
Concave or convex first?
So I put in with the dual rod reduction, I put in the convex first, but technically I'm not really locking it in. I bring it up to the screw heads, but not in the screws. So technically, if there's any rotation or actual correction with the concave rod, I'm actually lifting up the concavity, and the axis is it's not locked in. So it's in the plane of the rod that you have created a cantilever correction, but it's not locked in. So you can actually derotate the whole spine, and you get much better kyphosis corrections. And if you talk to some others like Shyam Kishan, he does a similar technique. Anand Tambe, he does a similar technique. And it really works well.
Perfect.
We heard you talk about those double thoracotomies. So usually we've done a couple of those, and actually we've struggled in the post-operative period with lung issues and all. What's been your experience handling those? Do you have special preparation before you take them up, especially those double thoracotomies?
You've got to discuss this with the anesthetist. If you're doing a double thoracotomy, you've got to see which levels you're doing it and whether it's going to help you. So we also call it the bucket handle thoracotomy. So you're going to have at least 2 or 3 levels between the two ribs if you really want to maximize the effect of the two openings in your chest wall. The other thing to think of is sometimes you can do one very well placed thoracotomy, and you can do osteotomy of some other 2 or 3 levels below. and that doesn't create as much of a violation of the chest wall. Then you repair the chest wall really well. So you get your ribs together, and you have these extra sutures that we use, these thick ones, to go around the ribs and tie them. But the main thing, I think, is with the anesthetist, because what they would do is, get the patients on BiPAP soon, and just get those lungs working really early and get them up going really soon. So there's a lot of work here and a lot of discussions with the anesthetists. You may have to keep the patient in the intensive care unit for a few more days than required. It is a lot of work, but if you do all the right things, it is very beneficial.
Perfect. I think in view of time, we need to move on, Priyank.
Yeah. So we'll get our next speaker in. Thank you so much, Mr. Mehta. Our next speaker is Dr. Mukund Gundana. He is a chief surgeon. He is an orthopedic spine surgeon, chief surgeon at the Basu Spine in Texas. He has done a lot of work on degenerative spine and spinal injuries. But apart from spine, he's also a very good pilot and has a degree in biomechanical and electrical engineering. And we want to hear those 5 new techniques which have really worked for you. Mr. Gundana, if you could share your talk, or if you want me to share your talk, it looks like you're somewhere outside.
Yes, good morning, good evening, good afternoon, everybody. Can you hear me?
Yes, we can.
Okay, if you could share my talk, that would be great, because I'm working on a cell phone and I don't want to screw it up.
All right, I'll do that.
So while we're getting it ready, so I was asked to discuss 5 techniques and technologies that had worked for me. And there are so many things to talk about. So I thought, let me talk about 5 techniques and technologies that have worked for me that I have used in the last month. So let's be very recent about it. The first thing I wanted to talk about that has really changed the way I do cervical fusions is posterior percutaneous. If you could go back to the first slide, posterior percutaneous cervical facet cages. Before, when I was trained at UCLA, we used to do anterior posteriors and these big giant exposures posteriorly, stripping all the muscle. And it was never great. And those screws are hard to place, especially at the bottom. And so when these types of devices came out, they were a blessing, because they're not as good as open lateral mass fixation, but they're very good. They're very easy to place. And so for me, if I do 3 or more levels, it's going to be a front back with posterior percutaneous facet cages. If it's 2 or more levels in anybody who I don't think is metabolically great, like a poorly controlled diabetic, it's a front back. If it's 2 or more levels in a moderate or heavy smoker, it's a front back. And if it's an adjacent segment, then it's typically a front back as well, because I know that my anterior column fixation is probably not going to be as optimal, especially if I can't negotiate an old plate or something like that. And we also know that there are increased stresses at adjacent segments. So this has been a very nice technique for me. This is a case I did last week for cervical fusion C3 to 6 in somebody with multi-level foraminal stenosis. Next slide. Another thing that has really helped me a lot is bone harvesting during surgery. I was always concerned that with the suction traps, they've been around for a long time, but with suction traps, I always wondered about contamination of the graft, because we always know that the suction is constantly sucking and all the dust and dirt in the room is going through our bone graft. So what I do is I have a separate small amount of suction with a separate suction tip. And when I'm drilling with my drill, I switch the suction to the suction trap. And during the rest of the surgery, I use regular suction. And it just takes a few seconds to switch it. So I can get a tremendous amount of bone from these arthritic degenerative facets, 5 cc's easily, if I was to do a 1-level T-lift on a hypertrophic facet. And sometimes I can get 7 or 8 cc's if I do bilateral facet resections to reduce some sort of deformity. And this is a picture from 3 days ago of me with bone graft that I got from a one-level TLIF with unilateral foraminal stenosis, just removing the lateral facet for a minimally invasive TLIF approach. Next slide. I know there's an SI joint fusion talk later here, so I'm not going to dwell on this, but I would just say that after a good lumbar fusion surgery, when the individual returns and says, I have back pain, and you don't know what to do, and you send them to pain management, and they have lesser good thoughts of your surgery, there's nothing like saying, you know what, this is sacroiliac joint, I can fix this, fix it quickly with a very small surgery, and all of a sudden patient is happy again. So it saves your results from a good lumbar fusion surgery. These two cases I've done in the last month. Different hospitals I work at have different contracts with different vendors. So on the left, we have one type of implant, and on the right, we have more of a cylindrical implant. Next slide. By the way, I didn't count sacroiliac joint fusion as one of my 5, so that didn't count. Cervical disc arthroplasty has been amazing. It is so easy to place. There's no instrumentation anterior to the spine, and it's faster than ACDF, and patients get back almost immediately. Within 10 to 14 days, they're resuming normal motion. These are 2 different implant systems I put in the last month. Some of the one on the top is a peak type implant. The problem with the peak type implant is that it's hard to see sometimes in the lower cervical spine, especially at C6-7 when the shoulder is in the way. So you need to have an implant with a solid metal tray sometimes as far as the lower cervical spine goes. But in the upper cervical spine, any implant will do just fine. The peak implants, the metal implants, they're all fine. The main thing with these implants is they all have different characteristics. And some of the earlier implants I felt were actually hypermobile. They're beyond physiologic in mobility. So the teaching back when I started doing them in 2008 was keep it loose, keep it small, don't put too much height. The problem is if you have a hypermobile implant like the one at the bottom, and it's not tall enough, it can slip a lot. So when I use a hypermobile implant, especially those earlier type implants, I will upsize it a little bit and tighten it so that it's not too loose. The newer implants are a lot more physiologic, and you don't need to upsize these sizes. Next slide. I was a peak guy. As soon as the cages came out to be big, I always felt that the cages were very, very small when the peak implants came out. And when they got to be appropriately sized for my tastes, I began using them. And I began to see these CAT scans where there was no interbody fusion through the peak cage. And I was wondering, well, why not? That should be where it should be. And then all the studies have started coming out saying how bone is not, peak is not a friend of bone. So solid peak creates a fibrous layer, and numerous studies are coming out showing that. So I've moved over to titanium implants. There's 2 types of implants I use. One is an all titanium 3D printed cage, and the other type is a titanium plasma spray coated cage. And each of them have their good and bad points. With an all titanium cage, I can really hit it into position and not worry about fracturing or deformity or breakage. But of course, it's difficult to see fusion. On the other hand, if with the peak cages, the latest studies are talking about delamination and micro wear of the titanium end plates causing inflammatory changes. So there are concerns about how tightly bonded that titanium is to the peak. But in my opinion, regardless, whether it's an all titanium cage or a peak with a titanium spray, it's clearly superior to a peak cage. The next slide. This is something that I anytime anybody talks to me about a tool that I use that has made TLIF very easy. It's pedicle screw distraction. And everybody wonders, okay, if you're going to distract on your pedicle screws, how will that not potentially damage the screws even before you're finishing the case? And so what I have in my toolbox are two 4.5 35 millimeter pedicle screws. And I use them over and over again. They're just like tools for me, Cobbs and curettes. I put my 4.5 millimeter, 35 millimeter length pedicle screw. I beat it up, yank on them, pull those bones apart. And then when I'm done, I put in my final screws. And then I put my screws back in the box and they're ready for the next case. You can reuse pedicle screws hundreds of times. There's no problem with that. So there's no issue with cost with additional pedicle screws. Additionally, with distraction, it obviously helps prevent a nerve root injury because sometimes the nerve can occupy most of the foramen, and you can come a little bit more lateral and get out of the get out of the way of the traversing route. If there's a revision and we're worried about getting too close to the canal, stay a little more lateral and stay completely out of the canal. Don't worry about the route. So this is a case I did 2-3 weeks ago of a Degen Spondy L45. You can see the distractor on the screws on the second picture, pulling them apart, and then the reduction afterwards. Also with pedicle screw distraction, the end plates are much more carefully preserved. We don't have to use too many shavers. We don't have to use box cutters. We don't have to use any of those things because it pulls apart nicely. The one thing I do recommend with the pedicle screw distraction is that it is not the primary tool to pull the bones apart. I usually put in a flat spreader and spread it up to 8 millimeters. Then I start catching it up with the distraction. So the distraction isn't to pull the bones apart. It's to keep the space open and don't let it keep on closing every time you take out your paddle distractors or your shavers or whatever you use. Of course, if the bone is amazing and those 4.5 millimeter, 35 millimeter pedicle screws have great purchase, I will yank on those screws and pull those bones apart from the start. Unfortunately, that's not usually the case, as we don't typically operate in people with phenomenal bone. I typically T-lift from the collapsed side, so the bone is better on that side. And I'm not afraid of it because with the screw distraction, I can keep those end plates apart, no problem, and the cage goes in very nicely. Next slide. And these are 5.5 really as SI joint. I didn't count that. We'll count it as half. 5 things that I've done in the last month that I thought would be interesting to talk about. So I'll see you next month in India, and I'll open the floor to questions.
Thank you so much for your interesting presentation. Do we have any questions for Dr. Gundana? I'll start with one. Dr. Gundana, you spoke about those 3D printed cages that you've been using. Are these patient specific or they are just they're developed by 3D printing technology?
They are not patient specific or custom cages. They're just standard 3D printed cages. There are a lot of them on the market these days, and I haven't found one that's bad. The one that I use has a articulating inserter. So when I put it in, I can turn it almost 90 degrees with the inserter still on the cage, and I can really bang it. You don't have to worry about it.
And what's your experience with this newer materials that are coming out there? Like there was in between talks about tantalum cages, which works with the similar principles of the hip replacement prosthesis. So any experience with that?
I have no experience with tantalum cages, although that they have been shown to me. Tantalum is a much different type of metal, and I think it creates a lot more MRI scatter, and that's a concern. The titanium 3D printed cages don't scatter as much. I thought when I put the titanium cage in there, after that, my MRI will be ruined. It does not get ruined. But you put one tantalum bead on a peak cage, and good luck with that MRI.
Interesting. And regarding the suction traps that you were speaking about, do you use them in all of your cases now?
I use them in all of my cases where I do fusions, and only in the lumbar cases. I don't find that in the cervical cases, I'm able to harvest enough bone to make it worth it.
And
So
has it
the
reduced
suction
your...
trap?
No, please go on.
Oh, yeah, I don't use DBM anymore. That's gone. And so I mix it typically with crushed cancellous allograft. And I put a little bit of blood in there, and it creates a nice blurry putty. And it's also very radio dense on the fluoroscopy, so you can see exactly where your graft is because it's bone.
Any reason for not using DBM? Okay.
The reason I don't use DBM is for a couple of things. Number one is that it's expensive, and the suction trap costs in the US about $100, which is, I know it's a lot if you convert it, but as far as DBM goes, it's $100 versus $2,000. Also, the bone paste that I get, when the device that I use has a plunger, and you push hard on it, and it will squeeze out all the blood and will create a very dryish bone paste. But if you put DBM in there, it turns into too mushy a substance, and it doesn't have that consistency that makes you feel good. So I typically use crushed cancellous allograft, which again in the US is extremely easily available and very inexpensive. For 30 cc's, we pay around $300 or $200 for that.
Cost, yeah. But otherwise, it's really useful in revision cases. I have found it really useful, the DBM.
I find it useful in every case where I'm doing, even a T-lift, and I think, okay, I'm just going to do a small burring of the lateral portion of the lateral facet so that I create a little pathway for my cage. I'm not going to take down much anything else. And then I still use a trap, and it still comes out to 3 or 4 Cs. And that's great.
Yeah.
Great. And in your cervical disc that you do, how often are you struggling with heterotrophic ossification? Like, do you take some special precautions to make sure it doesn't happen?
I have accepted that it's going to happen no matter what. I've been doing disc replacements now for a long time, probably going on 15 years now. And so I have a good amount of long-term follow-up. And I will say that almost all of them will come back with at least one or both levels fused. So what I tell my patients, and of course, we bone wax the bleeding edges and use an end plate. That's a very big end plate covering thing that doesn't have any bone on the back or front. One of the reasons I think that disc replacements should be properly sized is simply because you don't want any bleeding cancellous bone on either side of the disc, which can cause a fusion. But I tell my patients, I say, this disc replacement might be mobile for the next 5 to 7 years, which is 5 to 7 years more mobility than you had if I fused this. But yes, absolutely. I mean, 10 years out, they're almost all fused.
And then between the two discs, the one with the peak end plate versus the metal end plate, which one do you feel has a better outcome on the long term?
I only have used metal end plates for the long term. The peak end plate stuff has come out very recently. So I don't have any long-term outcome data on the peak end plates. The advantage to the peak end plates, I think, isn't the end plate itself, but it's the overall mechanics of the devices. The later devices, I think they realized that there's such thing as hypermobility, and they have started creating devices that are a little bit less mobile because it's almost too mobile and can create loosening of the end plates because they're yanking on the end plates. They're too mobile. So for me, it's not necessarily peak or metal. It's more a question of, is it a modern or an older implant?
Yeah, I just want to ask one thing. You said you're not using peak anymore. You're preferring titanium. What's your experience with the carbon cages?
The only carbon fiber cage I've used is the Depew Leopard cage. And I used that a long, long time ago. And I broke 2 of them trying to impact them. And I stopped using them because I was just too nervous about it.
Okay.
So my experience is limited, but my experience is you have to be very careful with carbon fiber cages because they're brittle.
Perfect. Any other question to Dr. Gundanna? Thank you, Dr. Gundanna, for a beautiful and wonderful explanation and the new things which we have all learned and your experience you shared. Thank you once again, and looking forward to see you in Mumbai next month. We move on to the next speaker and our faculty from Canada, Dr. Ganesh Swami. We welcome you, Dr. Ganesh. He is practicing at Alberta in Canada, and he's got extensive experience of around 2 decades in complex reconstructions and adult degenerative deformity. We would like to see how to minimize complications in adult deformity, and that's very interesting for all of us. Over to you, Dr. Ganesh.
Good evening, and thanks very much for having me. Can you see my screen okay?
Yes, yes.
Okay, thanks so much. So yeah, thanks so much for asking me to give this talk. You know, I have a lot of experience in adult deformity, and I also have many relatives with adult spinal deformities. And so some of you may be treating some of my patients, some of my relatives. And so it behooves me to talk about it. So what I'd like to talk about today is what is different in elderly adult spinal deformity patients, or ASD, and touching on frailty, cognitive impairment, and delirium risk. Nutrition is also an important part, which I will not talk about too much.
Ganesh, mode, can you make it, it's on presentation mode, so the slides show.
Yeah.
Yeah.
Is that better? Okay. And then I'm going to talk about communication, goals, expectation setting, goals of care status, and then finally about interventions, smaller interventions, limited fusions, and how to organize large interventions. This is probably no surprise to anyone here, but degenerative scoliosis surgical treatment is effective in the elderly. This is a table coming out of the PED study from AO Knowledge Forum. First author is Chris Nielsen. And when stratified by age, you can see that ODI improvement at 2 years is quite significant, even in the age group of 70 to 74 and over 75. So elderly patients certainly improve with surgery. I think I'd like to spend a few minutes discussing frailty. This is a really important concept to recognize. It's essentially a method to describe decreased functional status and resiliency with age, and it's measured and defined in many different ways. So it's most important to recognize it, and there are many scales and many different published scales, all varying in complexity and data points. But the principle is basically to identify those who are frail. And I think this clinical frailty scale, which is a Canadian scale, is quite easy to use. You can see the pictures in front of you. And the problem is that the clinical frailty index may be the most easy to use, but not super applicable to patients because there may be intersection with pain and cognitive dysfunction from the pain medications that our patients are having. So it's also important to measure cognition, and you can use a mini-cog, which is a really easy thing to administer in your clinic. 3-word registration, clock drawing, and then 3-word recall. And 15% of our patients will screen positive for cognitive dysfunction. So why is it important to identify frailty? Well, firstly, it affects survival. So this patient, this single center study from Arbeck et al. Suggests that patients with moderate or higher frailty have significant mortality rate, up to 12% in frail patients and 6% in partially frail patients at 5 years. So this is a big problem. In simple lumbar surgeries, frailty doesn't affect adverse events in the elderly. But in adult spinal deformity, many patients and many papers suggest higher revision rate, longer length of stay, and more mechanical complications and more delirium. So what can we do? How can we prevent postoperative complications in elderly ASD patients around frailty? The first possible intervention is to institute a perioperative seniors health program, or POSH. And this will require organization and coordination with geriatricians and pharmacists, but it's probably well worth your time, as in this 2020 publication on the left, where delirium rates can be much lower. And what do? Well, they use multiple different approaches, intraoperative and preoperative, and perioperative. First of all, they decrease medications, particularly benzodiazepines and anticholinergics, and then regulate sleep-wake cycles when the patients are in hospital, continued use of glasses and hearing aids, and early postoperative mobility, increased family involvement, better intraoperative fluid management. All of these will help. The next question is whether patients are frail because of aging, or ASD itself worsens their frailty. As I mentioned before, there's a lot of overlap, as both conditions impair mobility. But this paper by Passius et al. Would suggest that operative intervention itself could decrease frailty, and patients who don't have operations for ASD may remain frail or get even more frail. And so this raises the question, can surgery improve frailty? And can it improve life expectancy in the frail? And I think there'll be many more papers on this in the coming years. I think clear communication is a must, and obtaining informed consent is difficult in this patient population, who often are in pain and they just want you to make the decision for them. So there's a lot of nuance. And to illustrate the difficulties in decision making, Hadgaonkar et al., as in the, and I posted their picture on the bottom right there, reported that 20% or 21% of patients regretted choosing surgery after ASD, and responded that surgery actually causes them harm. And they suggest that older patients with depression were 4 times more likely to have regret. So that's a sizable and big problem that we have on operating in the elderly. So what can we do? Again, take your time in the consent process, bring in the family, frank discussion on the risks. And then I think you have to be very explicit about expectations. You can ask questions about what the patient expects, and that can include back pain, leg pain, function, stiffness. And then you can offer your prognostication. I think the surgery will allow you to be better in this and that domain. And I think if you don't, then you'll have more dissatisfied patients. In one of our major Canadian database studies, Ram Prasad et al. Found that 30 to 50% of patients found that surgery doesn't fulfill their expectations. And in fact, more worrisome, 17% said none of their expectations were met with surgery. Moving on a little bit to surgical decision-making. While we can all agree that decompressions are necessary when needed, fusion and alignment goals are still quite controversial. And this is because of this paper by Renaud Lafage et al. From 2016, and suggesting that as age increases, less sagittal plane balance correction is acceptable to achieve Oswestry Disability Index thresholds. So you can see this in this table, and you can see that in the increasing age groups, PT can increase, PILL mismatch can increase, and SVA can increase and still achieve ODI thresholds. Then they went further and said, well, what about mechanical complications post-op? And in their cohort, they suggested that basically accepting a higher PILL mismatch or SVA, or particularly PILL mismatch, led to less mechanical complications such as PJK. And this has led to this concept that maybe we should undercorrect our elderly patients. There is some controversy on this, of course. This is a graph from Dial et al. From Bridwell's NIH randomized controlled trial data set on ASD, and age-adjusted offset targets had no effect on mechanical complications. So really the jury is still out on age-adjusted goals. Let's take a look at a few cases now. This is a patient of mine who was 78 at the time, is now 81, with lupus and type 2 diabetes. Primary complaint is back pain, 5-minute standing tolerance, 25-minute walking tolerance, and a large PI-LL mismatch. You can see that she's very stenotic, frail. So I did 2-level decompression, and she's extremely happy. Large changes in SRS and MBI, patient standing and walking much better. So that's a win with a small cost, and we didn't have to do anything about the sagittal plane balance. There's another patient who's 72, has endometriosis, non-alcoholic fatty liver, otherwise reasonably healthy. I had first performed a decompression for Codd-Aquino syndrome, and actually you can see the staples in the left-hand pictures. But she was really quite disabled from sagittal plane imbalance. So the problem was her bone mineral density was extremely low. She had been very immobile for a number of years, poor nutrition likely. Hounsfield units at the UIVs in the lower thoracic spine was 104. So we put her on Forteo, and then as based on the CT, we decided to perform a limited intervention. When even in lower bone density cases, there's a lot of sclerosis around the end plates, and so that gives you an opportunity to use interbodies. And so we use a couple of laterals and anterior at 5-1, and Smith-Peterson's or Ponte's at the back, and got her a nice correction. She's nicely matched, but she's developing adjacent segment disease. And as you can see in these frail patients, she has a lung mass that is now being investigated for cancer. So other things take over their medical care. And that's the same as in this case. 72-year-old woman, rheumatoid arthritis, obese, already has some mild cognitive dysfunction, visual deterioration, osteoarthritis of the left hip. But she was really imbalanced and really very disabled. So we first performed a lateral to a lower thoracic and staged lateral and posterior intervention. Her spine is really stiff. She needed PSO. And then developed PJK within 6 to 9 months, revised her up to upper thoracic UIV, and much better now. Her spine's, and she's now out 3 years and is doing reasonably well, but she needed a hip replacement on the other side, fell, developed a periprosthetic fracture, and that's the story in these frail patients. So in summary, I think you should recognize frailty and cognitive dysfunction and partner with geriatricians. You should have explicit conversations with patients and caregivers, and choose wisely. You can have decompression sometimes acceptable. Limited fusions can be useful if the deformities are flexible, and large interventions required well-structured teams. I think geriatricians are hard to find in India, and same thing in Canada. But hopefully that we can work together to improve care of these elderly patients. Thank you.
Nice presentation, Dr. Swami, and a lot of things are quite similar in Western world as well as this side of the world, where this is a very big problem to all of us. And do you think the world is going towards less and less fusion or implanted surgeries in adults, looking at frailty, osteoporosis, adjacent segment disease, implant failure?
That's a difficult question again. I do think that, intervention, if done successfully, is a dramatic intervention and really can change the quality of life for a patient. And, survival rates are going up. So people are aging more. Average survival in Canada is now 85. And in 15 years from now, who knows, could be 100. And so, and the same thing's happening all over the world. So I don't think we can just tell patients to go away and lie down for the rest of their lives. So, you know, we will require targeted interventions for each of these problems that you mentioned. And I think we'll be able to intervene more effectively.
Okay, just one question out of curiosity. What is the rescue thing for S2 AI screw revision if there is any loosening of S2 AI in these long revisions? How do you manage?
Well, I don't do S2 AIs. I use iliacs, and I don't have too many problems with it, to be honest. I am getting a little bit more interested on S2 AI for SI joint fusions in these long constructs. Dave Pauly and others have been talking about this with these large diameter SI screws that you can integrate as part of your construct. So, but I don't have experience with that yet.
And do you really supplement patients who are with severe osteoporosis, DEXA scores, and Priority scores with maybe 3 or 6 months of anti-osteoporotic regime before you intervene these deformities?
Yeah, absolutely. I think that's, again, it's quite patient dependent and it's UIV dependent. So I don't think, you know, a systemic BMD is as important as UIVs, Hounsfield units at the UIV. And so you can really tailor your UIV depending on where the Hounsfield units are greatest. But yes, I do think that anabolics are very important. I think the literature on that is quite clear.
Yeah.
I think you need to also be clear on that some patients have a nutritional osteomalacia and not just osteoporosis. And so those patients need to be treated differently.
Yeah, we are seeing a lot of people are talking about 2 or 3 months of anabolic steroid. Whether 2 or 3 months of therapy is sufficient or 6 months minimum is required. What is your experience?
I think in the severely osteoporotic patients, we've gone up to a year pre-op, and it really needs, you know, personalized approach depending on how osteoporotic they are.
Okay.
And do you brace these severely osteoporotic patients after surgery?
That's also a good question. Actually, AO Knowledge Forum, and it's led by Solcato, just came out with a survey on this, and the practices vary all over the world. The Asian surgeons use a lot of bracing post-op. I don't actually. I've not ever braced my patients, and I think if they're balanced perioperatively and your fixation is good, then you shouldn't need bracing.
All right. And have you ever faced patients with post-operative neurological deficit because of stretching of the lumbar plexus and the femoral nerve after, you know, very good correction of these deformities?
Absolutely. Not so much neurologic deficits. We do use monitoring during laterals. And so sometimes you do see loss of MEPs with a big correction. But I think the bigger thing is actually psoas tightness. So you're taking someone and if you give them an additional 30, 40 degrees of lordosis, the psoas gets very, very tight. And in many patients, I do advise them to do some tummy time. So spend some time on their stomach and gradually stretch out their psoas pre-op. But in other patients, it just takes some time, 2-3 weeks post-op. They may need an admission to a rehabilitation facility, and gradually they do recover. And you know, in fact, that's a big problem whenever you look at all these immediate post-op films. You see patients have they're kind of leaning forwards because they can't retrovert their pelvis because the psoas is too tight, and they come back at a month or 2 months later, and they're standing in a much more natural posture. So that psoas lengthening, I think, is an important part of what you're talking about.
Thank you, Dr. Swami. It was a wonderful presentation, and I think it was a global connect. We had stalwarts from the US, UK, Australia, and Canada. And it was a great learning for all of us. I would like our moderator, Dr. Abhay Nene, to proceed with the vote of
Yeah,
thanks.
just to extend a personal thanks because we were very keen to have all you guys here because all our people in India, all the young spine surgeons need to know who you are. And, the kind of stellar work that you're doing has to be kind of brought on the table. So I think this was great that you could spare time, and especially Dilip da, Mukund, Ganesh, thank you for staying right up till the end. And of course, Vishal, thank you. Alok, thank you. Jwalant, thank you so much. We missed Rajiv and Ashish, but in a way it freed up some time for discussion. So I'm going to say we didn't miss them. But I think the content was fantastic. And as you know, this is going to be run, continuously through the main program. And we really look forward to having you all with us in Bombay. Dr. Badani, thank you for ASSICON.
Thank you. Thank you all for participating and giving your time. It was a great session and a good learning experience of all the novel things that you all do. Thank you.
Dr. Chahal, thank you too for the ASSI. And FYI, this session is being broadcasted live on Ortho TV. So there are lots of viewers who have plugged in, and you could go back on Ortho TV and see the session and see how it went. So thank you, and hope to have a great time with you all in Bombay. See you then, and have a great day. Have a great Sunday, you guys. Thank you again.
Bye, everyone.
Thanks, everybody.
Yes, sir.
Thank you, everyone. See you soon.